Morning. Again, I'm a general surgeon in El Paso in the William Bowman Army Medical Center. I'm going to talk about reoperative criteria, specifically indications for revision and reversal. I have no disclosures, and obviously the views expressed here do not reflect the Army, the U.S. government, William Bowman, etc. What are we going to talk about today? So we're going to specifically talk about indications for conversion or reversal of bariatric anatomy, inadequate weight loss, and complications of the bariatric procedure itself. We're not going to talk about acute perioperative indications for surgery such as leak or hemorrhage. We're not going to talk about non-bariatric procedures such as internal hernias, ventral hernias, transgastric ERCP, etc. So if you look at the ASMBS data, looking at the incidence of bariatric surgery annually, you can see that it increases not surprisingly. But if you look at that and you break it down by procedure, I think it's a bit more interesting. The lat band shown in gray shows a consistent decrease in frequency. The sleeve shows a consistent increase in frequency, actually exceeding the Roux and Y in 2012-2013 area. The bypass holds fairly strong, still retains a fair market share, but is decreasing somewhat. Most interesting though, if you look at the green segment on the stacks, those are the reversals and revisions. In 2011 through 2013, that was about 6% of the surgeries performed annually. By 2016, that increased to almost 14%. So that's a significant increase. And it makes sense. As you have more bariatric procedures performed annually, you have an increasingly large population of bariatric patients walking around with their bariatric anatomy. Some of them are developing complications, and some of those patients obviously are going to require surgery to correct those problems. So the question becomes, who needs surgery? What are the indications? So when you talk about revision, obviously you're talking about failure or complication. Those are the two main categories that we're going to be addressing here. Failure, is it better for the patient to have lost the weight and then regained it, or is it better for the patient to have not lost it all? I don't think we know that. But that also begs the question, what exactly do we mean by failure to have lost adequate weight? And we don't really know. In fact, Mann et al. In 2015 looked at that specifically in the literature and pulled 51 different studies that addressed that question. And of that, 31, greater than 50%, gave no specific criteria for what that means. Of those that did specifically give a criteria, only 7 of them specifically said greater than or less than 50%, and of another 6 said less than 25%. So the data is not very consistent with exactly what that means. I think less than 50% is a standard that we're using, but it's not well versed in the literature. Chung et al. Looked at this in a similar fashion. He did a systematic review in 2014. He was more looking at weight loss outcomes after revisional surgery for failed laparoscopic sleeve gastrectomy, but some interesting data came out of that study as well. He looked at 11 different studies with 218 patients, and what he found, if you look at the data presented for each particular study, you see that they also don't present the criteria very clearly. Insufficient weight loss with no specific criteria was the most common indication stated, as well as weight regain, and only 3 of them actually had any specific guidance. So it's a big question of exactly what the indications are and at what point is it worth pursuing revisional surgery for someone who simply isn't meeting their goals. So I think that that's a question that needs to be addressed, and it's very important when we're talking about what are the indications. It's difficult to recommend an indication for surgery if you really can't define what the failure means. When we talk about classifications, there are a lot of different classifications that have been recommended for complications of surgery, early versus late, chronic versus acute. The Clavian-Dido system has been recommended as well. But in this case, because the surgeries create a very particular and distinct anatomy and the complications arise from that distinct anatomy, I think it's easiest if we talk about it by procedure itself. So we'll start with the band. It was started to be used internationally in the 90s, hit the US market in 2003 after the FDA approved it. It had an early high safety profile, adequate weight loss in the early stages, and it was a non-permanent option which was appealing to a lot of patients, people who didn't want to necessarily burn any bridges, so to speak. So it was very popular in its early stages. Now, as you got farther on and after several years, there were a number of studies that came out, particularly these 2 from Europe, ARTS was a Dutch study that looked at was a 14-year longitudinal study. Only 201 patients met that full 14 years, but of those, only 21%, the mean excess weight loss was only 21%, with complications arising requiring surgery in 50% of those 201 patients, mostly pouch dilatation and slippage, as well as leakage or fracture, et cetera, of the band itself. At the end of those 14 years, if you look at outcomes based on weight loss as well, if you combine that with complications, only 23% had a band in place that had met goals, that had not developed complications requiring removal. So I think that's fairly significant. If you look at the French study, they had 18-year follow-up, almost 900 patients. Of those, 56% developed complications, mostly pouch dilatation and tube complications as well, also slippage, reflux, erosion, et cetera. Of those, 61% required revision removal in a first surgery. Of those, an additional 145 patients required a second surgery, and another 13 developed a third procedure. So by the end of all this 18 years, of the 897 bands that were placed, 43% of those came out after 18 years. So what is the recommendation? Well, again, we don't really know exactly what the recommendation for failure is. We're assuming that it's less than 50%. But we need to really address that and figure out what that means, and is that really a good standard to go by. For complications of the band, the recommendation would be to remove it, and then based on their weight loss goals and what their status is, you would consider conversion. For the sleeve gastrectomy, as most of us know, it started as a first stage for BPDDS. It's found to have adequate weight loss without necessarily going to the BPDDS, so it was found to be an adequate surgery on its own as a standalone procedure. And it was popular based on its ease of use, and patients were comfortable with it based on its simplicity and safety profile. Outcomes after 7 years, Shore et al. Found that about 22% failed to achieve or maintain their goal weight loss, which in the early stages was 50%. And then another 18 to 22% developed new onset GERD after surgery. The 1% with the stricture and twist is not 1% of that 22%, but it contributed to that. So Chung et al., back to that study as well, he looked at the indications for surgery for his revision of the lap sleeve, and he found these 4 categories, and I think you can fairly easily lump these together into pouch dilatation probably contributing to inadequate weight loss, potentially, I think we could say that, and then GERD probably also including stenosis and dysphagia. So when you're talking about criteria for surgery for the sleeve gastrectomy, you're really talking about inadequate weight loss or weight regain, and GERD or some form of stenosis causing some form of reflux or dysphagia issue. So the recommendations with sleeve gastrectomy, again, we're talking about the less than 50% excess weight loss, probably a good standard, but something that I think should be clarified and elucidated further in the future. And for GERD or stricture, as long as you don't have an external etiology such as a hiatal hernia, et cetera, you would consider conversion or adding a LINX procedure, which I think we'll probably talk about in another part of this conference. So the Roux gastric bypass, when you're talking about that, the question is a little bit more complicated. Now you're talking about, do you revise it or do you actually reverse the procedure and try to go back to a more normal anatomy? For revision, Ajmal et al. In 2016 reviewed his own institution, had 3,917 bypasses, of which 2% underwent revision. Of those, he didn't look at success from a weight loss perspective. He simply looked at anatomical complications, of which weight regain was included based on enlarged pouch, GG fistula, and short Roux limb, which was the vast majority of patients. Chronic pain, marginal ulcer was a reasonably large group, and bile reflux, malnutrition, and erosion contributed a little bit. Interestingly, there was no mention of stenosis or stricture of the GJ anastomosis, presumably because the group was too small, but there was no mention of that in there. Specifically, when you're talking about a marginal ulcer, you need to evaluate for the common etiologies. I think this is fairly straightforward. Once you've ruled those out and optimized them medically, and you've ruled out a gastric fistula, then you would consider thoracic sympathectomy. There is data to support it. In my personal experience, it's not extremely effective, but the data does indicate that it does have a reasonably high success rate in the publication. So for the marginal ulcer, If you cannot manage it and control it based on medical management, if the patient has significant bleeding, either acute or chronic, causing anemia, malnutrition either from a stricture causing PO intolerance or simply outright pain causing PO intolerance, or pain in itself, not necessarily leading to malnutrition, that would be an indication to consider revision surgery. For the gastric fistula, some of these are incidentally found on CT, et cetera, where the patient doesn't necessarily have any complications or symptoms. However, if it's contributing to weight regain of the marginal ulcer, chronic point, or severe GERD, I would definitely consider revising this patient and discussing that option with them. Reversal is a much more interesting question. Shore et al. Looked at 100 patient status post-reversal at over 35 articles, and he found a plethora of indications throughout those articles, mostly being nutritional and hypoglycemic. So if you lump them into kind of those two broad categories, with protein and micronutrient deficiency, excessive weight loss, et cetera, considered a nutritional complication, and then dumping and hypoglycemia kind of included with dumping syndrome, postprandial hypoglycemia, you can see that those are the major indications that have been presented for having undergone reversal of the Roux-en-Y gastric bypass. Now, endogenous hyperinsulinemic hypoglycemia doesn't necessarily fall into dumping or hypoglycemia per se, so we're going to talk about that one briefly as well. So also known as NIPS, also known as adult onset nocidioblastosis, many of the pathology studies that have looked at the etiology of nocidioblastosis shows a significant hyperplasia of the beta islet cells. And some of the newer data looking at the actual etiology of that hyperplasia is implicating GLP-1. Now, it's early, and again, it's somewhat more incidental than damning, but there is a consideration that GLP-1 may be at the etiology of that. So diagnosed through ruling out any extrinsic etiologies of insulin, the positive selective arterial calcium stimulation testing would indicate that it is a pancreatic etiology and is not insulinoma based on radiologic assays. So what are you going to do about it? The studies are relatively small. I think the largest one that I saw was 11 patients for people who underwent subtotal pancreatectomy, which in case studies does show good results, but again, these are isolated instances. Reversal is the same. There are case studies that have been presented where they had good results from the reversal, but that's not ubiquitous. For consideration of reversal for this indication, the recommendation is to consider a G-tube. Patients who respond well to feeding through the G-tube would presumably respond well to a reversal. But again, there's not a lot of data on that, so that would be something to consider if you're looking at doing a reversal for someone with nocidioblastosis. So the recommendations for reversal or revision of the Roux-en-Y gastric bypass, again, with a failure, it's difficult to give a strong recommendation when there's not a consensus on the indication. If we're assuming less than 50%, then you could probably go with that. But again, that's something that we need to look at and reinforce that indication in the future. For revision, the indications are somewhat less clear, but for marginal ulcer, gastrogastral fistula, and stricture of the GJ, those are fairly straightforward and would definitely indicate revision. And then for reversal, malnutrition and severe dumping, those are relatively straightforward. But for the hypoglycemic episodes, again, a lot less straightforward. So in summary, for failure and inadequate weight loss across the board, it's difficult to say. The recommendations are somewhat broad, so that would be an excellent future study. You need to rule out anatomical etiologies such as a pouch dilatation or GG fistula. If you are considering reoperation for regain of weight loss, you would want to repeat the bariatric assessment pathway and make sure that there's not a non-anatomic issue for their weight regain, and counsel them aggressively. This is a risky procedure, and the patient needs to be very aware of what the possible outcomes for that would be. And complications of the procedures themselves, that's very complex. I'm not going to go into that again. It's very specific to each procedure. So it's very long-winded if we were to do that. So thank you.